Okay, good morning, everybody. So I am delighted to welcome you to our officially our last virtual medical grand rounds of the academic year. But just stay tuned at the end for some announcements related to that. So I don't want to take too much time with introductions. I think you all know by now our dream team here, Robin Harrison, from Workplace Health and Safety, Dr. Stephanie Smith from IPC at the university site, and Dr. Lynora Saxinger, who has been co-chair of the amazing work that's been going on with the scientific advisory group at AHS. They kindly agreed to do a second virtual medical grand rounds for us as we get ready to lift off. And so without further ado, I'm going to give it over to Robin.
Okay, thank you. Thank you. So it's an honor to be back and to co-present with my colleagues. So we felt we had to do something different for you, so we've reversed our order. That's our big move here. So I'm going to start first, and I am doing stories again, and then Dr. Stephanie Smith is going to do the heavy lifting with some evidence, and Dr. Saxinger tells us she's going to give you a view from the stratosphere of what lies ahead. So we do not have any financial disclosures to make in relation to this presentation. So 2020, what a year. So many things have happened, and I know we're going to all remember this year for quite some time. And it's been interesting, with no disrespect to Mr. Elon Musk intended, of all the things that have happened, including this rocket launch, the first time in a decade apparently, this was the most eye-catching figure of that whole event. And I think this caught some of your attention as well. I couldn't take my eyes off of this because these people are so close. There are no masks. I had to scour to see whether it was a file photo from the last launch, and actually some news outlets were using those, but this one was actually taken in May. So this is from our neighbors to the south, where we know they were lighting up in red with active COVID-19 cases. So I didn't see physical distancing here. I didn't see masks. I didn't see a small group. And so this picture was hard to reconcile with everything that was going on. So over the next 45 minutes, we're hoping to achieve 3 objectives. So I'm going to try to take you on a whirlwind tour of global and some of our local information on COVID-19 outbreaks as we relaunch. And from that, I'm hoping to tease out some emerging themes. And then, as I said, Dr. Smith is going to follow with some evidence on whether there's any validity to that, and then we're going to look towards the future. So I think it would be prudent for us to start with a few basic definitions. We've been talking about wave 1, and effectively what that means, it is the wave of cases we saw in our local epidemic as part of this pandemic. So our wave 1 started March 5th with our first case, well after the January 21st first Canadian case. That was fortunate for us, actually. But wave 1 refers to the first wave of cases, a peak, and then a decline. I want to introduce, because I don't hear everybody talking about this, but when cases start to climb again, it's really more likely a resurgence or a rebound, not necessarily wave 2. And if you look at pandemics from years past, and we've seen about 3 per century, and although this is our first coronavirus pandemic ever, with past pandemics, you typically see the second wave happen, 3 months after the first, and once your first one is gone, so that means your reproduction numbers below 1, you have almost no cases or transmission. So we're not there. We're at this time called relaunch or reopening. And what is interesting about this is I don't think relaunch or reopening is all that well defined. And I have concern that this can sometimes lead to confusion on public messaging. So this is a look at our curve. This is, I suppose, I believe, our wave 1. And you can see May 14, which was the beginning of the phase 1 relaunch. We reopened. And if you really zoom in on your right-hand side, the cases are going up. It's not completely unexpected because we've relaxed some of the control measures that we think have worked. So this could be, over here where we are this week, the beginning of a resurgence or a rebound. But I want to highlight through this presentation that a rebound or even a wave 2 are not inevitable. This is a new pathogen. We don't know it's going to happen. We do still have some things within our control. So this is a slide that I had prepared back in March for a presentation as a general overview of COVID-19 for the John Dossiter Ethics Center, actually. And I've borrowed this image that's become famous by a Dr. Drew Harris in the United States, and I'm sure many of you have seen it circulating on social media. I've added a few details to it, but essentially, I would argue that Alberta started at point A. We did, as you know, a wonderful job in this province of testing early to be sure we caught our epidemic curve, our wave one early. So we knew where we were and we had time to flatten that curve. I would argue that places like New York started somewhere closer to my arrow B, so that they commented, the peak came faster and it was bigger than we had hoped or anticipated. And so the things that were employed in those that could start over at point A were basic measures in public health that have come from study and examination of other pandemics and outbreaks. So stop importing new infections, which means travel restrictions. At least that's what it meant early for us. But in a healthcare setting, it means don't let people come to work ill. We limited visitors and we were checking patients for infection. So you stop that. Then you slow the spread by physical distancing and quarantine and self-isolate when ill. These kind of mainstays are what have been employed. So now that we look after May 14th at reopening further and further, we're left with, well, what have we got that's different? And as I think most of you know, we don't yet have a treatment for all comers that will take this away from us, and we don't yet have a vaccine that is taking this away. So we're stuck with, what did we do in the last 3 months that was effective? And so this has been talked about a lot in the press. And as you know, it's been an interesting time with information spreading quickly, and the press has been driving some good dialogue. I liked this is one example. I liked the 4 C's. So as we relaunch, what should we be thinking about? The most recent message yesterday from our Chief Medical Officer of Health is COVID-19 loves a party, so we can't let our guard down. I've realized subconsciously I've been collecting quotes throughout this pandemic, and so this is my quote of the week from Dr. Dina Hinshaw. And I think it's sage advice. So as many of you have your summer holiday plans changed or canceled, I want you to dream of something beautiful and somewhere where you may be headed in the future. This is an image of Grasse in Provence. This is the heart of the perfume industry. People from all over the world have perfumes that originated here. And so what happens is that the essence of something is distilled down to all that one needs for something beautiful. And so I would like to take you through the outbreaks to find what the essence of what we need to keep over these next few months as we relaunch. So thinking about C's, I guess you would say confined spaces. So most of the outbreaks that have been described, first of all, some of them are published in peer-reviewed academic journals. Many of them have been media reports only. So for those of us that are very interested in this and are tracking these, it's actually been difficult to keep yourself organized. And I've got, personally, I realized I wasn't doing a great job. I was keeping written papers and all kinds of things. Very difficult to organize this. So I just wanted to highlight what I think is sort of neat. This group from the London School of Hygiene Tropical Medicine has pooled them into a nice spreadsheet. They pooled the outbreaks that were reported after searching through the lay press and published journals up until April 20th. And so they've come out with a few summaries, including this mention that most of them had less than 100 people affected. The exceptions and the outliers were areas of interest to me, like hospitals, elderly care homes, and some of the other things you see mentioned there. But this is just a neat way to do this. They made it open access, so you can all look at their list of over 200 outbreaks, and the link is in their paper, and here it is. It's just a snapshot I took to show you what they've done and how they've organized this. So I personally plan to keep mine organized this way, and I'll just build upon theirs. So, so from their notes and my notes, I want to add religious venues to that long list of settings that have been associated with larger clusters. But when you get into the details with outbreaks is always when you find the takeaway or the controversy and where we need more robust study. And so this is one example. The South Korea outbreak was an outdoor ceremony. How could so many people at one religious event outside, when we say outside is lower risk, become infected? But when they got into the details, they realized it was those that rode the bus to the ceremony that became affected. And it was those on the bus that were not near a window that were higher risk of being infected. This, I argue, it's indirect, it's not perfect, it's definitely not a randomized controlled trial, but there's a suggestion that being outside is of some merit, or fresh air might be helpful. I'm just going to sort of put a nod here to our scientific advisory group, as Dr. Lynora Saxinger is co-chair. And for anyone interested in singing, there was as you know, I think, a famous choir outbreak in Washington, which was published in EID. And with a pathogen where you have a case fatality rate at many points in time in many different jurisdictions of almost 2%, although I recognize there's variability there, it follows that when almost 100 people get infected, you might have deaths, and you might even see 2 deaths, and that's what happened. So these outbreaks are interesting, but they're also frightening, and they're really cautioning to us about where we need to be careful. And there have been other choirs, it's not just the one, but mostly media reports. Close to home, the Cargill outbreak is just one example from around the world of food processing plant outbreaks. And at first glance, you might look at this picture and say, they're close, they're working a long time, and it's cold in there. Maybe it's because this virus likes cold, and that may be. But again, once you get into the detail, these families, these are people living together, close quarters. There might be one bathroom in the home. They may not have had the same messaging as, say, for example, healthcares have about how to isolate within the home. I don't know. Maybe they did, but I don't know. And what else, by the way? Break time. So it's hard to be social in a big room like we just looked at, but you sure would want to get social at this time and look at the space. And you can imagine the loud talking in the hum of the crowd, which is a bit like being in a choir, in my view. So there are some themes. I gather, it's speculative, but when they start repeating over and over again, we draw from this. I want to add then conferences like the dental conference, particularly conferences that are multi-day. This was shown to be higher risk, where people go for dinner together. When you think what we do at medical conferences, we go to dinner. We go out to many sessions, lots of people in rooms without windows. A wedding where the father of the bride was thought to be an index case, a funeral in Newfoundland where a traveler, an imported case, may have been implicated. And I'm just going to give you a couple more of this whirlwind call centers. And when you look at these mapped out, it's the people sitting across from each other and close to each other on one side of the room only. They tested many people in this building and saw this cluster. This suggests droplet spread. People that are sitting close together, face to face for a long time. And then you can imagine the water cooler associations that might relate to this. We can extend that to the home. So the greatest number of reported clusters in all of the outbreaks have been in households. The data are imperfect. We don't have denominators. It's hard to make conclusive attack rates for this reason. A lot of it is published in the press and not scientific journals. But nonetheless, we see that there are clusters. And we also see that when the index case is quarantined, we can abort transmission. This is huge. For me, in my job, this means you need to counsel healthcare workers when you're ill, isolate from your family, and you have a hope of protecting them. So I just wanted to point that out. The risk is about 10% in a household, but the estimate, of course, is imperfect for the reasons I just mentioned. Clusters with fitness or dance. Again, indoors. This outbreak was interesting to look at how it was mapped from instructor to students and then from students to household contacts. So again, indoors, lots of breathing up close, face to face. It was a risk. This is a restaurant. The flow of air is thought by the authors to be the transmission method here. One also wonders, though, about fomite transmission. Did they all have the same weight, or what was passed around? That isn't explored in this article, but these are, again, trends compatible, I would argue, with the other. And so what I pull out of this is there's a lot of repeated contact amongst people. And so if we look at what has happened in our healthcare stories in Alberta, just bringing this local, our first case, as I mentioned, was March 5th. And our first healthcare worker case was the 10th. We didn't actually have a occupationally acquired healthcare worker infection until April 3rd, and then we had a first acute care outbreak. We've not had many outbreaks, but when we have, they have been associated with worker-to-worker transmission. And I want to highlight this because I don't think everyone is aware of this risk. It isn't just patients that pose risk. Unfortunately, we've also had visitors been implicated in transmission. And so I just mention that because I know we have visitor policies that are hard for for us to live with. And I guess this is one of the reasons why, but we have to find a way to find a balance. So repeated close face-to-face, because when we contact trace, we find people are repeatedly having many contacts. Those are the healthcare workers that get infected. So there are some analogies from those global outbreaks. It begs the question, what should we do or continue to do within the healthcare setting? And so I want to quickly move through this so that I can give time for my co-presenters. So I just have about 3 more slides, but I want to remind you of our testing dashboard. We called it testing rather than infection because we started with the assumption that we would test lots of workers, that's what we're doing, but not that they would all get infection. We are working really hard to prevent it, and I hope that you agree the numbers suggest it's for the most part as good a news story, I guess, as we can get. But I want to highlight here, despite this, if we look at positive test results, there was risk almost every day since March 5th. So every day a healthcare worker has a positive test. It's not all acquired at work. Most of it, the vast majority, is in the community, but it poses risk to their coworkers and the patients or visitors every day. 53 out of the first 70 up to May 14. So we have to be vigilant. So as lockdowns are lifting, the themes emerging is that business is open, but we don't just run back to normal. I would like to say I think we should tiptoe outside towards somewhere that we think is a right balance. And we are now going to talk about the things that we should maintain in the workplace to mitigate the risk that I just mentioned. And so with that, I'm going to turn it over to Dr. Smith.
Thanks, Robin, for the kind of introduction. And so I'm going to kind of focus on the hospital setting. That's my job in terms of infection prevention and control. We're really looking at how we can keep our hospitalized patients safe. So I think that, as all of you have seen, as we move into our relaunch strategy, we've seen that hospitals are getting busier. So we have, more surgeries, et cetera. But I think we have to realize that really that doesn't change the population we serve. So we still are looking at, in the hospital setting, having the most vulnerable people for severe COVID disease. And so nothing has changed in terms, nothing has changed in terms of what we need to do in the hospital to protect our patients and, by association, also protect our healthcare workers. And I think what we need to realize too is that, when a person comes into the hospital for one reason and ends up getting a respiratory infection while in hospital, there's a significantly higher mortality compared to the community acquired infections. So I'll just take you through some of the surveillance that we have, and this is not specifically for COVID, but I will talk a little bit about some of the data on COVID as well. So we do viral respiratory surveillance and infection control during the influenza season. And just to kind of give you a snapshot, the last viral respiratory season, we had 298 patients that were admitted with infection or developed infection in the hospital. They were on average about 61 years old. And when we look at how many had hospital-acquired viral respiratory infection, it was 17%. So quite a high number. And when we look at how they fared compared to those who had community-acquired viral respiratory infection, we see that a larger proportion had required admission to ICU, and the ILI-related mortality was almost double. So just to kind of drive home the message that, if we end up actually giving a patient COVID or other respiratory viruses in hospital because we're infected and we bring it to them, their mortality is actually significantly increased. And we see this from some data from COVID-19 as well. So there's been a number of outbreaks reported in a variety of healthcare settings. And one such outbreak has been published. It was in Wuhan, so it was fairly early in the pandemic, but there were 138 hospitalized cases of COVID-19, and 12% were originally admitted for other reasons, but then acquired COVID-19 in hospital. So again, this is the nosocomial
population, and 53% of them required intensive care compared to 22%, again suggesting that the hospital-acquired group is particularly susceptible to adverse outcomes. So I think that kind of leads to, so how are we going to protect our patients? So, I mean, certainly some things stay the same, right? So the appropriate point of care risk assessment and appropriate PPE donning and doffing, as we've always done. And I think those key messages continue to be incredibly important. But then there's the extra things that we've introduced with this pandemic, which is really the continuous masking and the physical distancing. So when we look at the evidence base that we've used to decide on these measures, I will be the first person to say that the evidence is certainly not perfect. It's heterogeneous, so it's often a mixture of hospital and community settings that we're looking at. It's difficult to separate the contribution of one measure, as often multiple measures are implemented, not implanted, at the same time. We have very few randomized control trials, and I think it certainly highlights the need for that. Often the studies don't actually look at compliance with the measures. And so, even though we're looking at, for instance, masking versus no masking, it's not always clear if that masking was done continuously or if there were breaches. So despite that, we still need to come up with recommendations that are going to try to protect our workers and protect our patients. So we really have to look at the evidence to date. We have to look at extrapolation from other respiratory viruses and other pandemics. We look at mathematical modeling, and then, at the end of the day, we also have to a certain extent, employ the precautionary principle. So we'll start with the physical distancing. I think, certainly this is a logical one. And there's lots of funny posters about how far apart you need to stay. So this is one of the Canadian ones, of course, we have one caribou apart. And so, I think the question not so much is, does physical distancing reduce the chance of transmission? I think everyone can appreciate the fact that if you're not close to someone, then it's going to be very difficult to transmit this virus, given that it's generally transmitted through respiratory droplets. I think, there's certainly lots of question about how far is far enough. And so, the UK has come out and said, well, 1 meter is fine. And we've stuck with 2 meters, and Australia says 1.5 meters. And so I think, the answer really is it depends. And I think all of us acknowledge that there is going to be a huge variation in terms of how far droplets are going to spread, depending on the activity in question, the symptoms, the viral load, etc. So, I think that the 2 meter distance is based on a combination of science and practicality. And the science is really from observational data from MERS, SARS, CoV-1 and 2, and indirect evidence from some influenza surveillance that I'll present. So this article from the Lancet was just published fairly recently by Derek Chu et al. And I think that, there's certainly been a lot of criticism on my part as well about it, but there are certain things that I think you can take away from this study, and it does kind of, I guess, nicely look at all the available evidence. How it's grouped together, I guess, may need some further dissecting. But I think basically what they did is they looked at the issue of physical distancing, and there, again, the evidence is not perfect. There were 29 unadjusted studies, 9 adjusted studies, 5 were from SARS CoV-2, and then the rest were from SARS and MERS. They found that there was an adjusted odds ratio of transmission comparing closer, less than 1 meter, to further, greater than 1 meter, of 0.18. So basically, you're looking at an absolute risk reduction of 12.8% transmission with shorter distance versus 2.6% with further distance. So, I think you can already see some of the issues with looking at these studies when they're looking at less than 1 meter, is that actually face-to-face 0 meters, or is it 0.9 meters? And then the further greater than 1 meter, is it 1 meters? Is it 2 meters? So again, I think the evidence is not perfect, but certainly it would suggest that with increasing distance, then you have less risk of transmission. So again, this is just summarizing what I've already said. And again, this is just looking at as we get further apart, the risk of transmission decreases. So there's also some indirect evidence that physical distancing on a population level actually makes a difference in terms of our risk of viral respiratory infections. And this is mostly from Australia, who is just in the middle of their influenza season. So you can see that they have slightly different physical distancing rules. So they have to be a kangaroo apart, or 4 koala bears apart, but 1.5 meters as opposed to 2. So this is, this is kind of, I think, interesting data. So this is laboratory confirmed influenza cases from Australia for this season. And so you can see that into the orange bars in 2019, they had quite a significant influenza season last year. And had this increasing number. And it looked initially in January and February that the 2020 season in the light blue bars was going to be fairly similar. So they were having similar numbers of cases. And then in March, they implemented many of their physical distancing and lockdown rules around COVID. And you can see that these numbers just tailed off dramatically. So I think that does suggest that, with physical distancing, you can reduce the transmission of respiratory viruses. And we see similar data in a number of different countries. So this is just another example of Singapore, and this is just ILI surveillance generally. So you can see in the red line, this is for 2020. So they physical distancing measures again started kind of just at this spike, and this may have partially been COVID cases, but then has come down nicely compared to previous years where they would have had ongoing elevated numbers of ILI. So again, the physical distancing data is the data quality is quite poor. Some of it's indirect, and there's certainly variability in distance, but all studies do show the same directionality. And I think that as much as possible, it does make sense until we either have appropriate therapy or vaccine. And I was trying to change this, but I think when we talk about our children, give them an inch and they'll take a mile. I think for us, in terms of deciding on the 2 meter, I think we give people 6 feet, and generally they probably will actually start moving closer and closer together. But our hope is that you give them 6 feet and they'll learn to avoid you. Okay, so going on to masking, I think this is maybe a little bit more controversial, and I'll try to go through this quickly. But I think, certainly masking, there's a couple of things, right? So it's obviously designed to prevent the spread of respiratory secretions, and it's most effective if worn by the infected person. But there's still protection if worn by the uninfected to prevent you from being contaminated by someone that is infected. So, I think this all started in terms of continuous masking with the implementation started when concerns were raised around pre-symptomatic, post-symptomatic transmission. And so in healthcare settings, the issue of continuous masking has really been implemented to protect patients from healthcare workers and protect healthcare workers from other healthcare workers. So when we look at the evidence, though, for mask use, the vast majority is actually around prevention of transmission if you are wearing a mask and the person that is infected is not. So when we look at the litter, it's fairly heterogeneous. It's based on MERS, SARS, as well as SARS-CoV-2 and influenza. And often it's evaluated in combination with other interventions, both hospitals, clinics, and in public. And there really have been no studies to date that have evaluated continuous masking versus intermittent masking. Again, this is a two paper that summarized a variety of studies looking at this issue of mask versus no mask. And I would just like to highlight that although they do make some conclusions about N95 versus surgical or procedure mask, none of these studies actually compare those two head to head. So when they say that the N95 may perform better than the surgical mask, it's actually based on a simulation that they've done within the study. And they're basically taking a bunch of heterogeneous studies and comparing them to another group of heterogeneous studies, which is, I think, somewhat problematic. So I think what we can conclude here is that there does seem to be an effect of masking versus no masking. And with decreased transmission if you are wearing a mask. And so again, they looked at, face mask versus no face mask. There's 10 adjusted studies with an adjusted odds ratio of 0.15. So again, if you don't wear a mask and you're in contact with someone that has either SARS, MERS, or COVID-19, a 17.4% chance of getting infected versus 3.1% with a mask. So I think, again, there's a few other systematic reviews that have basically shown the same thing. And I just highlight this study because I thought it was interesting that they actually separated out studies from Asian countries versus Western countries and found that there were actually greater reductions with mask use in Asian countries. And I think that's not entirely surprising. I think in Asian countries, they're much more of a mask wearing culture and they probably do it better than we do. So I think we have something to learn from them. And so when we look at the indirect evidence, so these are more kind of simulated studies. So this actually was a study that looked at virus shedding in exhaled breath of people that were infected. And so I think this actually gives us a little bit more information about how much reduction there is if you are infected and you wear a mask. So they sampled breath with and without surgical or procedure masks in people that had influenza or coronavirus, not specifically COVID-19. And basically what they found is that this was the viral load of people that had nasal swabs or throat swabs. And this is specifically looking at coronavirus. They basically found that, yes, they could detect virus in breath samples, albeit in a small number of people, without a mask and none with a mask. And the same was found for particles that were less than 5 micrometers. So again, they could detect without a mask in breath samples, but not when they had a surgical or procedure mask on. So I think that, in summary, I think without a vaccine and without treatment, we really don't have any defense against COVID-19. And so as we relaunch and things are getting busier and opening and there's more social interaction in the public, I think that we really need to be careful in the healthcare setting. We really do need to try to maintain that physical distancing if possible. And when we can't, then we absolutely need to perform hand hygiene, mask, and use appropriate PPE when caring for symptomatic patients.
So I called it a joffying of my presentation. I have a lot of slides for what I'm actually going to say, and some has actually been touched on. So do not be afraid. Buckle your seatbelts. And this part was going to be talking about what's next. I'm going to say that there's no crystal ball. I'm putting a link down there to the Scientific Advisory Group, which is a terrible, terrible acronym, SAG, really. Anyway, didn't make it. List of reviews, because we actually do have some coming up that are going to be posted where we looked at the literature around modeling of the future. And also we looked at reopening healthcare. And so models all suggest that cycling of public health interventions will be required And the goal of that is to suppress viral transmission and limit excess deaths. And so when you look at the possible scenarios, most models fall into kind of smaller waves for 1 to 2 years. Some models actually predict a large fall peak, possibly related to changes in transmission with changes in temperature, humidity, and the way people congregate, and then waves for a couple of years. Other ones basically suggest that we're going to see a slow burn, more not the second wave so much as the resurgences that Dr. Harrison was talking about. And with that, I think we all recognize that we have a need to balance our healthcare system capacity to manage surges and all other healthcare needs. This has become increasingly clear. And also the need to actually let the world proceed, education and economic activity. So the scientific advisory group, we've done a whole bunch of reviews. You can search for them all on the webpage. They vary a lot from kind of questions that we did for public health, like singing risk. We have some risk factor and risk prediction tools. We have some inpatient care related things on non-invasive ventilation. Not all of them are posted yet. Some more are going to be posted, but just to know that these are resources that we actually do also currently go back to update, which is a lot of work. So considerations in the second wave, we think about the virus, we think of the population at risk and control measures. So there's a lot of interest in humidity and temperature. I don't think that the summer has saved us. I don't think hot weather and humidity has saved anywhere else. I think that the fall might make things worse. The population at risk, seroprevalence studies actually do suggest that even in places that have had extremely severe outbreaks with a lot of death, the overall population seroprevalence after that is 5 to 10% at most across larger populations with pockets of higher seroprevalence, which would suggest that herd immunity is a long way away. And then for control measures, the WHO has kind of laid out the things that you need to have in place to prevent second waves. And so ability to detect, isolate, workplace prevention, minimize outbreaks in the highly vulnerable, manage risk of imported, exported cases, and have an engaged community. And in Alberta, cycling public health measures means there's currently an open, watch, and enhanced breakdown, where open is low level of risk. Like, notice that does not say no level of risks. No additional restrictions in place, and less than 50 active cases per 100,000. And I'm going to point out that we never actually got quite to that point in our first wave. So when our first wave was at its highest, under this rubric, we would still be open. There's the watch category where there's 10 active cases and more than 50 per 100,000, with monitoring and discussing the need for additional measures. And if you go to the website, you can toggle over any community greater than 10,000. It'll tell you what the state of that community is right now. So this is not going to be a province-wide re-lockdown. This would be a city, town, large town, or regional lockdown. And then enhanced risks are where the risk levels need new public health measures for sure. Now, I both love and hate ecologic data, but when we look at this type of bar, you can see that the total lockdown, like the shades of orange to red, are where the restrictions are lighter. And there's a whole bunch of places that are still seeing cases of 25 to 40% increases per week on an early basis, with lessening the degree of lockdown. In other places, there are burgeoning epidemics, even with greater stringency, which is really non-reassuring. And it tells us that lockdowns are a very effective but blunt tool, and they are not actually all there is. And so what is the end game? Herd immunity, most models based on the current estimates of the reproductive number suggest that we need 60 to 85% of the population to be infected to have herd immunity. But without containment, we could expect over 90% of people would be infected. And if we set the infection fatality ratio around 1%, we'd be looking at around 40,000 deaths in Alberta. And based on how many people know, you'd know 6 people who died of COVID in that scenario. And in people with professions like ours, it would be much more, because we actually often have that many patients even that we follow and know, in addition to the other people we know. So effective vaccination is really what a lot of people are looking at in terms of our end game strategy. COVID and immunity to coronaviruses can be short, especially the kind of scruddy cold type coronaviruses that are around. For SARS, the humoral immunity seemed to wane quickly. The T-cell immunity does seem to be more prolonged, which suggests that on re-exposure, those people still might actually be protected. And that's important to know when we look at the serology studies. Most people appear to develop antibodies. The best time to detect them is likely 3 weeks or so after infection. And decline in antibody titers has been raised as an issue in this long paper, but I'm actually not necessarily convinced the neutralizing antibody titer was a little more robust. And the vaccine platforms are actually pretty exciting, and I'm one of the optimists on this. There's more than 10 vaccines in clinical trials, and that number is probably changing as I speak. And there's more than 200 additional vaccines in preclinical development. And there's a lot of different approaches being explored. And so the kind of most standard, these are the vaccines that we commonly use, are protein and adjuvant vaccines, so they're recombinant vaccines. Inactivated virus, there's some trials. Importantly, there's some more novel platforms that are being used. So nucleic acid vaccines using mRNA or DNA plasmid and engineered viral vectors are also being used. And some of these have an advantage, like the mRNA vaccines, where you can actually mass produce them. They're very stable. They're fairly cheap to make. The problem is that we actually don't necessarily have exemplar vaccines that have been used already in this domain, but it's a common one because they'd be easy to scale up, and they get T-cell immunity and antibody immunity. And then engineered viral vectors are also of interest in terms of getting a good immune response. You actually either modify a harmless virus and pseudotype it like SARS-CoV-2, or use virus to deliver genes coding the target proteins to host cells, and you then make your own viral proteins. And the ones that are being studied most right now are adenovirus vectors, and there's lots of interesting discussion there, but I could do an hour on that alone. We might be seeing some efficacy data by September to October 2020 on some of the initial ones that have already gone through phase 1 trials. My thoughts on this are kind of that I'm not looking for a vaccine. I'm actually hoping that we get more than one effective vaccine through phase 3 trials. I'm hoping that countries can actually develop, like we actually have at least 6 or 7 in development in Canada. If we can develop and manufacture our own vaccine, it'll actually help prevent worldwide bottlenecks. There is an effort to streamline the testing of these by collaboration. And there is an actual plan to start manufacturing some of the more promising ones before the phase 3 trials. Start manufacturing before the phase 3 trials so that once the trial is done, you'll be able to deploy. And also at the same time, we have to continue looking at the natural immune response. So I do have a couple more slides, and I'll try to hustle. You've seen this already. I'll just mention that early on, it was mostly travelers. Then the second part of our initial epidemic was long-term care. And then the big peak there was the large workplace-related outbreaks, mostly in Calgary and in the South Zone. And then we have this kind of slow, grumbling, non-reassuring burn over the last month. Well, really less than a month. Now let's go back to the original Alberta model prediction that actually really people probably remember well. It predicted 16,000 to 32,000 deaths. And those models were based on essentially an untrammeled epidemic. That was what we were trying to prevent. And then you had elevated and probable peaks. What we actually had as of yesterday was less than 8,000 cases and 154 deaths. And so I think people actually, that kind of undermined confidence in the modeling. But in fact, remember, the modeling was predicated on not doing all the things we did. So to me, this tells us that we actually were both lucky and to some extent did it right. If you apply the Ontario rates to the Alberta population, they fall right in the range of the Alberta models. In fact, the Quebec rates were higher than the elevated Alberta predictions, and the Ontario rates actually were very close to the low Alberta predictions. And so the models actually tell us that we did do something right, and probably we were also lucky. And I got these from Dina Henshaw. The peak severe outcome rates per capita are useful to look at, and keep in mind the numbers here. So for Quebec, the total death rate per 100,000 was over 6. In Alberta, it was 0.3. And if you actually look to the other place everyone keeps on looking at, the deaths per 110,000 in Alberta and Sweden. In Sweden, it was 12-fold higher, and Quebec is actually up towards the Sweden end. So these were all within the range of what could have happened here. This could have happened here. And when we look at severe outcomes, as you'd predict, hospitalizations first, a lot of younger people were still hospitalized. Quite a few ICU admissions also in younger to middle-aged people. You'll notice that the 80 plus tended to have a lower ICU admission rate, likely related to goals of care. And then, of course, the death rate was really, really horrible. for the very elderly. So what about the slowdown? It seemed really quiet for a while. It was very anxious, and yet, you know, if you weren't doing clinical work, boring time, but if you were on scientific advisory work, not boring. Maximum inpatient plus ICU census was 94 patients. In Calgary, they were seeing mostly 2 to 4 hospitalizations per day, around 20 to 25 patients per site, and this highest single day was 12 admissions at peak. And the stage 1 target for open beds that had been decided upon was 1,800. And in hospital beds, we actually used less than 5% of the planned capacity for COVID. ICU, we used a lot more of the capacity. As a matter of fact, Calgary went to 95% of their stage 1. So to me, that tells us that that model was useful for ICU, but less useful for hospital. And when you look at how fast we were able to open up, this is part of some scientific advisory work that's probably going to go up next week, but it's been discussed at ELT. And so when you see our usual capacity and then the fairly abrupt drop, because really the overt drop started in mid-March, we actually dropped to 20 to 30% of our occupancy overall. And that was across most areas. The first and quickest and biggest drop was in surgery because of elective surgeries being deferred. But there was considerable space made across many different areas in the healthcare system. And there was some variability, but you know, a lot of sites actually cleared out a lot in preparation for what we were afraid might happen. So we opened up basically 20% of our capacity. Our average census dropped by 500 to 600 beds. That was not as many as was anticipated for stage 1, but we didn't come close to filling that. And there was this rebound of admissions actually kind of before we really officially changed things. So things started to creep back up over April, and that kind of told us, and when we looked at the types of admissions, that there's kind of a floor for opening beds safely and reasonably. And beyond that, some chronic conditions really do need to stay in hospital or come back. So I think that we have to look at under current 10% under current occupancy as a range that you can play with without necessarily hurting things too much. And the R0 peak preceded incident hospitalization peak by roughly 2 weeks and inpatient census peak by 4 weeks, which tells us also that there is some time. So with those things, what is on the table right now is the idea of a dynamic bed buffer rather than keeping an empty hospital that we should try to predict and open according to what's going on in our community and at a basically community and zone level. This is the inpatient early warning system dashboard. It actually shows predictions, and you can set for how many days in the future to show, and it's actually more accurate at 10 to 14 days. How many beds based on the current R0 in the community you would expect to need, and you can do it by zone. And the newest model is actually the R0 model. There's a doubling time model in April 14th tab, which is also actually pretty accurate. And when we look at how well this performs, the R estimate appears highly accurate. Here's our actual cases per day in black, and then the blue is the estimated cases per day. So looking back, this actually looks to work well. And so I'm hoping that that's what we arrive with, because we're not going to be able to run everything at 100% because some capacity is diverted for other COVID-related issues. But we should be able to safely ramp up and ramp down services to better care for people and respond to the emerging epidemiology. And so for therapeutics, I will spend very little time. There's a lot of things that are being discussed. I thought I'd be saying it's looking bad for hydroxychloroquine and we're awaiting news of remdesivir, but instead hydroxychloroquine is done. The nails are all in the coffin. Remdesivir is promising, and surprise, dexamethasone is a contender. I won't talk about the hydroxychloroquine story too much, except to say that desperate polypharmacy observation trials with poor endpoints and underpowered randomized trials, possibly falsified data, and Twitter hype created a bit of a situation. And as we untangle the situation, it seems like this medication is not likely to be useful for treatment or prophylaxis. And really, we should learn from that whole process, hopefully, because it just was kind of a mess. Remdesivir, fascinatingly, when this was all going down, they started increasing production because early signal was that it could be a coronavirus. And it's a very difficult thing to synthesize. And it's actually made in Edmonton. We had 90,000 courses in Edmonton. We had the biggest worldwide stockpile of this drug in Edmonton, and then it was sent to California to be packaged and sent out for trials and expanded access. And currently we can't get it, which is funny. Time to clinical improvement, like a composite endpoint, is used as the outcome measure in the remdesivir trials. And the trial that I think is most interesting is still incomplete. It's a preliminary report. 11 days versus 14-day recovery. Mortality, there's a trend to benefit, 7.1 versus 11.9%. There's some trial data from the company suggesting that 5 to 10-day therapy equivalents overall, except for maybe in severe disease. And there's ongoing trials using this with immune modulators. And I want to leave time for questions. So I'm just going to show you the Kaplan-Meier's are pretty clean for people who are on supplemental oxygen. So earlier in disease, there's a pretty good differentiation there. But for mechanically ventilated patients, it is much, much less compelling. Now, dexamethasone has been part of a lot of mixes. And so when you looked at the early descriptive data from epidemics in China, Italy, Spain, other places, dexamethasone was often tossed in because of its possible benefit in ARDS, pneumonia, septic shock. The Oxford-based RCT press release was picked up widely and suggested that it's a life-saving drug. And I don't think that that's wrong, but I think that the press release might be a bit misleading. Cuts deaths in ventilated patients by a third and death in admitted patients on oxygen by a fifth. But there's a lot of trust issues now with retractions and bad publications in high-level journals. But in this case, there was a full protocol available. This was part of a well-designed study with multiple arms, and additional data came out in preprint quite quickly. And the overall mortality in this study was very high. This is the hydroxychloroquine data, which they had a pretty high number of patients, and the hazard ratio was non-significant, but extremely non-reassuring for hydroxychloroquine, and they stopped that arm. Then in the usual care arm, there's 25% mortality and 40% mortality in the mechanical ventilated arm, compared to, with the use of dexamethasone, 21.6% mortality overall and 29% mortality with mechanical ventilation. So this drug looks useful later. And there's your differentiating curves for oxygen patients who they got oxygen at 92 to 94% or lower, and ventilated patients, which I think looks compelling enough that I would consider this practice changing, but it doesn't preclude further trials, particularly combinations. And if you actually put everything on one side, my friend Francisco did this on Twitter, but he basically took what we know so far for day 28 mortality data for dexamethasone and remdesivir, and the pretty useless remdesivir and mechanically ventilated, likely useful dexamethasone and mechanically ventilated. And so it might just be a staging issue. So antivirals early. Convalescent plasma appears to be safe and has possible benefit, and there is a trial enrolling across Canada, including here. And other immunomodulators are something to watch. Not currently recommended outside of trials. There's not great data, but it's promising. And I'm wondering if it's going to end up being more for late disease as well. The other issue, of course, is a signal of superinfection with some of these agents. So my takeaways, 3 months of COVID. We gained time to plan and prepare. That was crucial. And COVID has resulted in unprecedented speed of adoption of therapies with unproven benefit, a proliferation of poor quality trials now evolving to good quality trials, spread of conspiracy theories and myths, widespread public interest in science without, I think, adequate support for scientific communication that optimized that. And we learned that evidence-based medicine can be done quickly and collaboratively. There's some good examples. Getting the info out there may not help answer the questions, and be careful about preprints.
As predicted, that was outstanding. Thank you, all three of you. So I'm going to have a question for each individual. I've asked Robin to just give us an overview. I know there's a lot of anxiety because of a local outbreak we have currently at one of our acute care sites, and to just give us some broad comments on her outlook on that.
Okay, thank you, Norman, for that question. So I cannot give specifics about the outbreak and I believe you're referring to the Misericordia Hospital, which many of you have heard about in the news, and some of you will work there. But I can tell you some information. So first of all, to really highlight the point that the investigation, like any outbreak, is ongoing. And as I was showing through those case reports, it's very easy to come up with the wrong conclusions or wrong assumptions with outbreaks, especially if you rush discussion, try to come up with an explanation, there's usually a huge early demand, what happened, or what's happening, or is it under control? And so it's better to do the investigation systematically, thoroughly. And the mainstays that we've seen with our outbreaks to date has been time and time again that if we go back to the basics of prevention, do not come to work ill, screen your patients, not just for your point of care risk assessment when they're admitted, but at every interaction with them. These things we know help, and then adding to that the continuous masking and so on. So the nice thing, if there can be anything nice about having something happening that you aimed to prevent, is that it's a very good opportunity to tune all of that up, and that is definitely being done. The other thing I want to just point out is that outbreaks, every single one is unique. And so there's a difference between short stay units and longer term stay units. And so it's interesting, when you think about a short stay unit, it's kind of like having travel. If you look at those basic public health measures, you've got new patients coming in every day. It's risky every day. But the long stay unit, they carry different risk, because if you did have someone ill or there was transmission, then you've got that sort of grumbling situation. And so each outbreak has its challenge, but there is a very responsive team right now addressing that, and I'm very confident that they will have it under control, as has happened to date in this province with every even suspicion of transmission. We have tools, we know how to use them, and they've proven effective. So I'm confident this will be the same.
Thanks, Robin. I'm just going to ask you, there's a lot of controversy, as you've said, about universal masking and what public policy should be, public health policy should be. But even locally within our sites, we've all identified that we've all kind of let go, and people are walking around in acute care settings and other healthcare settings without even proper masking as healthcare workers. Do you have any comments, in terms of your thoughts about that?
I mean, I think healthcare workers have the same challenges as everyone in the public, in that, there's this message that we're relaunching. And certainly when you're out in public, it seems that, things are kind of getting back to normal, quote unquote. And I think that it's easy to forget that when we're in a healthcare setting, that we do have to have those extra measures in place. And so, I think we all need reminders that when we cannot physically distance, whether it's in a patient care area or not, that we need to wear a mask. And that's the area that I see the biggest, I guess, issue right now, is the public spaces, because, during the kind of height of the lockdown, there really weren't very many people in the hospital. So it may have been, easier to actually maintain that physically distancing in public areas in the hospital. But right now, it's really not. So you go to the cafeteria, you go to these other places. I do think that we need to be more careful, and we do need to be wearing masks in public areas. There will be some guidance coming out from Workplace Health and Safety, just really trying to drive home that message. And it is a directive. So I think that there will be some kind of stronger messaging around that.
Thanks. And that's, again, a plug to all the healthcare workers and people walking around these sites. Please wear your masks when you're not able to be physically distanced. Lynora, I'm going to give you the hardest one. Given we know there's challenges, and Robin showed that great slide at the beginning with all those individuals together at the shuttle launch. We've heard a lot in the last few weeks at Grand Rounds about the physical and mental impact of social isolation and some of the challenges that these last 3 months have brought about. And we've seen it in acute care, where people have been coming in with their chronic diseases acting up, or just haven't gotten the care that they needed. How do you balance that with the risk of COVID sort of coming back and the second wave and all the rest of it?
So I think it's been clear that we need to negotiate this tension between making space and having surge capacity and providing care. And that there's going to be a lot of negotiations along the way. And I think that it is possible. I mean, the experience thus far tells us that we can open the space quickly. and that there's some room to play from our usual occupancy levels, and that we should try to keep things as open as possible and as safe as possible, and keep on providing care, because we are also going to be following outcomes in chronic diseases and cancer care, and endoscopy deferrals and coming back with problems, and I think all those things are part of the mix. And this is a profound healthcare experience. And it's a very hard one. And I think that the only way that we can get through it is if we keep on doing the basics perfectly. Like, that is going to be absolutely crucial. And getting community engagement, because if the community is engaged and we are putting on the gas and the brakes at different times on the measures, but if they're complying with it, we'll be able to walk that balance without excess deaths. And we will hopefully get through to a vaccine. I mean, that's clearly plan A. But it's definitely a difficult thing. And I think people, including us in healthcare, are really hungry for a return to normalcy. And we have to be so careful, because normalcy is going to come up and put us back in square one. So it's a very difficult scenario. But I actually am quite encouraged, like going through that process and looking at our experience in the data. I think we can walk that line, and I think we can provide good care, and I think we can think about our social contact points and spend them wisely. Like, just be very careful a lot of the time, but if something's higher stakes, then okay, well, maybe you should do something outside, masking, that's sociable with families. Maybe sharing food isn't the right thing, going for a walk might be a good thing. And try to just think about your budget of contact and spending it the best way you can for your mental health, and try to get your patients to do the same thing.
Thank you. I think that was actually a very thoughtful, great response. So our time is up, and I just, on behalf of the department, want to thank these amazing 3 individuals. I mean, they have really carried the load, and in fact, I would say a lot of individuals within your division have been carrying a very heavy load these past few months. So thank you. I know it's not over yet, and so we'll have you back to update us in the near future. But on behalf of the department, thank you for this, and thank you for everything you've been doing. So stay healthy, and thanks, everybody.